Hello, everyone. This is Kate Berry, CEO of the National eHealth Collaborative. Thank you for joining us for our third and final Spotlight Learning Series on the Learning Health System. We are joined today by Dr. Charles Friedman with ONC, Dr. Richard Platt with Harvard Medical School, and Dr. Jeff Brown from Harvard Medical School and the Harvard Pilgrim Healthcare Institute. I'll be introducing our speakers in just a few moments. We are really looking forward to their presentations and to having an interactive Q&A session. Next slide. We have recently expanded our education program and rebranded it as NEHIC University. Our new class offerings provide a broad and deep view into the rapidly changing health IT landscape. Next slide. Before I turn it over to the speakers, I'm just going to give you a quick overview of our education programs. As part of our expansion, we created the NEHIC University Advisory Council. And as you can see from this slide, the council has representation from virtually every segment of healthcare: patients, physicians, hospitals, payers, academia, government, and more. This council is really important to us, and these people are helping to shape the curriculum, to serve as faculty members, to help us recruit faculty, and to provide additional advice to us. We are really happy to have them as part of our extended team. Next slide. Here's an overview of the new NEHIC University programs. We're offering Health IT Orientation, Industry Leader Briefings, Health IT Policy and Standards Committee Quarterly Updates, Guest Lectures, Health IT Trends, the Spotlight Learning Series, and a continuation of our NIM University 300 series. Many of these classes can be viewed on our website at nationalehealth.org. Next slide. This quarter, we're offering two Spotlight Learning series. One is on accountable care organizations, and the last class of that series is coming up next week on June 30th. That program that final class on accountable care will be moderated by John Glasser, who will also share his views on accountable care. The other speakers will be Dan Garrett with PricewaterhouseCoopers and Dr. Renee Carter, a practicing physician who is also with Accountable Care Solutions. The discussion on that program will focus on examples of ACO models as well as critical success factors, with an emphasis on health IT integration and how accountable care organizations map to the stages of meaningful use. And today's class is the final one in the other Spotlight Learning series on the Learning Health System. Next slide. The slides for this webinar are available at the URL on the screen. We will also make a recording available in a few days and a full transcript in about a week. You can also find other supplemental materials related to this program and the other classes on our website. Next slide. So during the presentation today, please feel free to type in your questions at any moment in the Q&A window at the bottom right-hand side of your screen. You can also send us an email or tweet a question or comment on your Facebook page, but please do type in your questions as they come up. Now, I'm very happy to introduce our speakers. First, we have Dr. Chuck Friedman. Chuck is the Chief Scientific Officer for ONC. He leads a group responsible for tracking and promoting innovation in health IT, for research programs to improve technology, applications of health IT that support basic and clinical research, for evaluation of all of ONC's programs, for programs to develop the health IT workforce, and for activities supporting global eHealth. Chuck also served as Deputy National Coordinator for 2 years prior to this current position. We also have Dr. Jeffrey Brown, who is Assistant Professor in the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. He is Research Director of the Therapeutics Research and Infectious Disease Program at the Department of Population Medicine and Director of Scientific Operations for the FDA's Mini Sentinel Project. Dr. Brown holds a master's degree in economics from Tufts University and a PhD in social policy from Brandeis. Dr. Richard Platt is professor and chair of the Department of Population Medicine at Harvard Medical School. He is an internist trained in infectious diseases and epidemiology. He is a member of the Association of American Medical Colleges Advisory Panel on Research, the FDA Drug Safety and Risk Management Advisory Committee, and the IOM Roundtable on Evidence-Based Medicine. Now I'm going to turn the podium over to Dr. Friedman.
Thank you, Kate, and good afternoon, everyone. I'm just so pleased that we have Jeff and Rich to be our main presenters today. I'm very much looking forward to their presentations. And what I'm going to do, primarily for the benefit of those of you on the webinar today who were not at either of the two sessions, is go over what we mean by a learning health system, and in that way kind of provide a context for what Rich and Jeff are going to present. For those of you who have been on one or both of the previous sessions, you are going to find this presentation very familiar. You may even know it by heart by now, but I will be running through it very quickly and hope it will still be useful to you to kind of get you in the spirit of today's proceedings. So here we go very quickly. There are a lot of definitions of a learning health system, but because the IOM has really been so prominent in advancing this concept, I'm going to provide you with the definition that they typically use, and I think it's a good definition to put in front of you as the framing definition for this series of presentations. So the IOM views the learning health system as one in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement and health care. That's a learning health system in words. I am still trying to come up with the best way to represent a learning health system in pictures, and this picture is the closest I have been able to come, and of course I welcome your suggestions for improvement. But think of the learning health system as a kind of federation of organizations and maybe even of individuals who will work cooperatively to carry out the functions of the learning health system that were described in the previous definition. There are some very important features to this diagram. One is the bidirectionality of the arrows. And this reflects the fact that the members of this learning health system, however it is organized, will both contribute to and benefit from its activities, contributing their data either physically or virtually, and I think you're going to hear today about some ways that data can be virtually aggregated for purposes of analysis and learning. And they will also receive and be beneficiaries of the knowledge that is generated through the studies and analyses the learning health system performs. Another feature of this diagram I'd like to point out is the representation of the functions of the learning health system in a cloud. We don't mean, although it's quite likely that what we consider today to be cloud computing will play an important role in the functioning of the learning health system. We don't necessarily mean by that cloud the direct denotation of cloud computing. But in that cloud is the notion that somewhere, somehow, the learning health system, in order to function as a system, will have to carry out a set of functions, including the ones depicted there: governance, patient engagement, trust, not so much as a function, but as an outcome of a number of activities that are undertaken in creating and maintaining the system, the establishment of standards, the ability to conduct analytics, and finally that all-important dissemination of knowledge in usable and probably computable form back to the entities that are part of the system. In the first session, I gave a longer talk where I made, I think, an important foundational point that, first of all, the National Health IT Agenda does indeed target a learning health system as a major outcome. And if you take a look at the new Health IT Strategic Plan, which has been out for public comment and now is in the final stages of clearance for release very soon, you will see that a learning health system is articulated as one of the 5 strategic objectives in that plan and also referred to elsewhere. Another key point is that meaningful use, as important and foundational as it is necessary but not sufficient to build a learning health system. Meaningful use will get us only part of the way there, from which a formula that you see in front of you, meaningful use plus some delta, is what will be required to get us to a learning health system. And also in the first session, I did make some points relating to initiatives that are underway in advancing toward meaningful use, which of course are generating a significant amount of momentum at this point. Here, building on one of the points I just made, is a representation of the soon-to-be-released new Health IT Strategic Plan, and you can see there the 5th goal, which is to achieve rapid learning and technological advancement. And as you listen to our speakers today, and perhaps as you listened to the previous speakers in the previous 2 sessions, you will see that actually concepts related to the learning health system are interwoven with the other goals of the plan, such as inspiring confidence and trust in health IT. If that confidence and trust in health IT does not exist, the learning health system, for example, cannot function. To illustrate a bit more about why I said meaningful use is necessary but not sufficient for a learning health system, you need only look to see why this might be true at the first 2 bullets of this slide, which distinguishes meaningful use as a status that is achieved individually by those professionals and hospitals that are eligible for incentive payments under the HITECH Act versus the learning health system, which, as its name implies, is a system. It's a system that includes these professionals and hospitals, but one that binds them together in such a way that they systemically can achieve goals that are only achievable by them acting together in a coherent way and not achievable by them acting independently. Here at the bottom of the slide, you see the same requirements for functioning and operation of a learning health system that were depicted in the cloud in the diagram that I showed you. And if you would benefit from a further elaboration on some of the points I'm making in these brief remarks today, you might wish to reference the article noted on the bottom of the slide from Science Translational Medicine. Because of what I have said about meaningful use being necessary but not sufficient, and the need for some delta on top of meaningful use to achieve a learning health system for the nation, a grand strategy would necessarily have 3 parts to it, and we really need to proceed with these simultaneously. Obviously, we need to build toward national meaningful use of health information technology as it has been defined for a first stage and is in the process of being defined for the second stage. We have to build this delta, and I think in the presentation today you're going to be hearing important things about what some of the aspects of this additional work, this delta, is going to need to be. And third, as important as the other two, as we move toward meaningful use and as we build the delta, we've got to do each of these things in a way that anticipates the other, so as these efforts mature, they merge seamlessly together into a functioning whole. So to close my remarks, let me just say that the learning health system as depicted here has been the focus of these three sessions. The first session was a general presentation. The second session focused on those aspects in the cloud which are whited out here because they will not be emphasized here. They were part of the second session, as important as they are, those being governance, patient engagement, and trust. And what we're going to hear about today from our excellent speakers are issues and concepts relating to standards, analytics, and information dissemination. So that concludes my brief remarks. If you have any questions for me that you don't have a chance to get registered during the session today, please feel free to write to me at this address. And also, as always, you can find much more information about many of the topics that I addressed in these remarks on our website, healthit.gov. Thank you very much. And Kate, I turn this back to you.
Thank you, Chuck. And next we have Dr. Richard Platt and Dr. Jeff Brown. And I think you guys are together, so I guess I'll just hand it over to both of you.
Okay, thanks very much, Kate. This is Rich. Jeff and I are going to trade off the speaking, so I hope we'll let you know when we've swapped. We're delighted to be able to talk about some of these ideas with you. Could we have the next slide, please? Our shorthand for the kinds of uses that Chuck described is secondary use, and our plan for the next half hour or so is to talk about the attributes and needs, to discuss approaches to aggregation and analysis, to work through an example of a living, breathing system that's a secondary use system, and then to talk about where we might head as a nation. Next slide, please. So by secondary use, we mean uses other than the direct care of individuals. And the kinds of examples that we have in mind are medical product safety evaluations, other kinds of public health surveillance, quality measurement, comparative effectiveness research, health services research, epidemiologic research. This isn't an exhaustive list, but it's the kinds of things that we include in sort of the first tier of secondary use activities. Next, please. This kind of use often requires information about defined groups of individuals. It often requires defined person time, meaning we know when a person is receiving care from the system. And we believe that we have complete capture of the relevant care that the person receives. And the reason for that is we want to be certain that if we don't see an event, that the event really didn't occur, that is not having evidence in the system of an acute myocardial infarction needs to mean that the person really didn't receive care anywhere for an acute myocardial infarction. And those are surprisingly stringent. Taken together, the three of those are surprisingly stringent criteria for many of the electronic data systems that exist now. On the other hand, secondary use often doesn't require real-time data. It doesn't require access to all of the information that's available in an electronic record, and it often doesn't require the most granular level of data that exists. That means that some of the some of the requirements on electronic health records that are used for direct patient care management don't exist in this environment. It's not necessary for many of these secondary uses to have the kind of information that a clinician needs to have when the patient is in the office. It's not necessary to be able to know everything about a patient's care or to know full details about it. Next slide, please. It's often the case that one needs to use data that exists in multiple institutions. That can be true for a variety of reasons, and we've listed some of them here. Sometimes one needs a very large population under observation to be able to assess rare conditions, rare treatments, rare outcomes, to be able to accumulate experience very quickly. That's often the case if one's worried about an epidemic in a population or wants to evaluate the safety of a medical product. In order to evaluate subgroups of interest, to do benchmarking if one's evaluating care across institutions or in regions, or to monitor health status. In order to do that, there are really sort of two key things that are needed. One is to aggregate information that exists in multiple places, and the second is to be able to analyze it. Next slide, please. So we're going to talk about how one might approach aggregation and analysis of data that lives in a number of different places. Next slide, please. We approach this by asking 3 upfront questions and then 3 secondary questions. So the first question is, what is it you actually want to know? We have found that it is a very clarifying experience to work with our partners to be as clear as possible about the specific uses that we're interested in, the specific goals, because it's our thesis that you can do meaningful. I'm using meaningful in a different sense here, but it's possible to make substantial progress reasonably quickly if you target the work to address specific kinds of needs, rather than saying we're going to build a global system that can address every possible need. We distinguish between information and data. We focus first on asking, what is it you actually want to know? And an example might be, we want to know the rates of a specific adverse drug event. And then we ask, what kind of data do you need in order to answer that question? So if your question is adverse drug events, you certainly need to know the number of exposed, the number who have the outcome of interest, and a bunch of other things. I don't want to suggest that this is simple, but in fact, it's typically a relatively small number of kinds of attributes that are important. The third thing to address is to ask, where will the data be stored? The 2 choices are the data can be combined into a central location, or they can be maintained in a distributed form. And if the decision is to keep them in a distributed form, then there are 3 more questions. How will the data be analyzed? Is a common data model needed? And if a data model is needed, what will it look like? So I'm going to hand the speaker to Jeff to take us through the next part of our discussion.
Hi, so this is Jeff Brown. This is my voice print. So given the requirements Rich expressed and the needs of a system, what I'll try to describe is, well, how do you actually make it work? So we have this first question of centralized versus distributed. Remember, this is in the context of a multi-site or a multi-institutional evaluation or study. So if it's centralized, we're sending all the information, all the data for everyone and all of their care to a central place. If you can do that, if you do that well, you've got all the data in one place and you can analyze it there. So it simplifies manipulating the data files so they're all in a single location. And in a distributed approach, you leave the data with the organization that is responsible for it, basically. It could be a medical group practice, a health plan, it could be a health information exchange, whoever functions as that data partner, they keep their data. So what are you doing there? You're obviously minimizing the need to exchange any PHI, move any really detailed information around. You don't need this big central data warehouse to secure. The data partners, by keeping the data in a distributed environment, the data stays with the people who know it best, and I think that's an important feature of this distributed approach. Regardless, both approaches, central or distributed, requires it requires really a great deal of interaction with those data partners, whoever they happen to be, because they know their data best. And in either approach, the level of data checking and characterization, it's a relatively big undertaking to ensure that you understand what the data look like, and that will happen regardless of centralized or distributed. Go to the next slide. So there's a reference at the bottom here. This is based on work we did, I guess, about 2 years ago for FDA as they were preparing to think about their Sentinel initiative that you'll hear about later. And I'll think about this from right to left, starting with the analytic programming. So if we're going to have to make this decision of how to create a multi-institutional network, there's a decision of, well, how do you want to do the programming? A single analytic program or multiple. Multiple meaning you have different teams of people all trying to write code based on the same protocol. So we ask a question, what's the rate of acute myocardial infarction? You can either answer that question with a single program, or you can ask multiple people to write that, to get that answer for you. So we've settled, and these were our recommendations, a single analytic program is the way to go there. If you choose a single analytic program, the next decision of a data model becomes very easy, because you really need a common model in order to have one program run everywhere. But that still leaves you with distributed or centralized, so you can still have either one would work. And we settled on distributed for really the reasons I mentioned in the previous slide and the ones I'll mention in the next slide. So we can go to the next slide. But as Rich described, to do most of the work that we want to be doing, you really don't need to exchange very much person-level data at all to answer safety, effectiveness, quality questions. So if that's the case, you'd prefer not to move that. You'd prefer not to move large volumes of person-level data if you don't need to. And the reality is you really don't need to. In addition, you don't really need that many pieces of information from the electronic health system, whether it's an EHR or a claim system. There's not that many pieces of data or information you want. In some EHRs, there might be 20,000 different visit types. Well, in a lot of the work we do, you want to know whether it's in the outpatient setting, the inpatient setting, a long-term care facility, or emergency department. And that's really it. And you can start to settle on small subsets of the information that are crucial. I mentioned that the knowledge of the data partner being important, and I think it comes up over and over again, that the data partners help you understand their data. And we've found that the data partners want to have control over who accesses their data and the uses of their data. And I think it's not just them wanting to have control. They also they certainly help you think through whether their data is appropriate to use for the question at hand. And sometimes it's not, and you'd rather they tell you that up front and you find out at the end when the analyses don't make very much sense. So next slide, please. I've touched on some of these. When you're analyzing data in a distributed model, a benefit is that you can the analytics are identical everywhere. It's one piece of code that runs identically at every site. You can do this in this distributed model, but you can often just share count data, as Rich described, the number of exposed and the number of outcomes. And you can do a lot of work without sharing really detailed patient-level data. If you need to have person-level data, you can really minimize it to, in nearly all cases, one row per person with a very limited amount of information in that row. And again, we're reducing the amount of information that we're moving around. You let the partners keep it, and you only move what's needed. So the next slide. So it seems complicated to create something like this. It's actually been, there's several living, breathing examples of what we'd call these distributed networks. The CDC's Vaccine Safety Data Link is probably the oldest one that has the most experience in doing this. It's a set of 8 health plans around the country, and they do active surveillance of vaccine safety. And this is really the approach they use, is sending a piece of code out, and they get summary results back. Rich will describe the FDA Mini Sentinel, and I'll also describe some of that also. And these others are all operating versions of distributed networks that have followed this idea of keep the data at the nodes and create a common data model and write a single piece of code that runs everywhere. I think I'm passing this back to Rich.
Okay, thanks. I'll just underscore one of the points that Jeff made, which is the importance of having the data partners be active participants in the interpretation of the use of their data. The fact that the data is all formatted the same way and looks the same doesn't mean that it means the same thing. And we've learned a number of times how important it is to have that kind of local expertise involved. We'll spend the next few minutes talking about the FDA's Mini Sentinel, which is a pilot project that we and a couple of hundred of our closest colleagues are conducting in partnership with FDA, and which is an example of we think of the way the learning health system has the potential to operate. Next slide, please. There's a fair amount of information about the Mini Sentinel on this website, so we'd be delighted to have you look at the website, give us input about any aspect of what we talk about today or any of the other things that Mini Sentinel is doing. Next slide. But the brief history of the Mini Sentinel is that the FDA Amendment Act of 2007 mandated that FDA establish the capacity to use electronic health data to assess the safety of drugs. And FDA is required to have an active surveillance program operational, taking advantage of information in the electronic health information of 100 million people by the middle of next year. And in response to that, FDA is developing its Sentinel program, which will address drugs, biologics, and devices. Next slide, please. The major activities that Mini Sentinel is engaged in are to create the capability to do active surveillance. That means prospective evaluation of newly approved agents. Also to be able to do very rapid evaluation of new questions that arise about agents that have been on the market for a while. And finally, to quickly assess the impact of FDA's regulatory actions. Second, in order to do that, we are creating a distributed data network that has both data resources and creates sufficient methods and capability to query and analyze the data. So thinking back to the earlier discussion we had about aggregation and analysis, that's where this lives. To create the policies and procedures and governance mechanisms to make it all work. And there's an additional piece of doing methods development in epidemiology and statistics to fill gaps that we need to address in order to do this work. Next slide, please. Because this is a substantial undertaking that relatively soon will be using information from many of us, we've been very attentive to privacy implications of the work we're doing and the concerns of the citizens whose data will be contributing to the information we take here. You'll find on the website a white paper that our privacy panel has created that addresses some of these issues. One of the reasons that FDA was instructed us at the outset to develop a distributed network is that it saw this as an important safeguard to ensure privacy, both for technical reasons and I think because of the sense of assurance that it provides that protected health information really stays with the organizations that already have it in almost every circumstance. Next slide, please. Our data partners are shown here. They include national health plans, care providing organizations, and some other organizations that create and use registries. Next slide, please. And the additional partners who provide various kinds of content and methodologic expertise are shown here. So I'm going to hand us back to Jeff to walk through the additional pieces of how the Mini-Sentinel addresses its data and analysis task.
Thanks. So, yeah, now that we have all those partners, how do we make it all work is really the next section that I'll try to go through. So, where did we start? We actually engaged with the data partners, and we decided early on to focus on the administrative and claims data, because those are the data that most people, that we understood best and been used for the longest for this kind of work. And then with the plan of building the model so it can be added and accommodate additional data. So we started with talking to the data partners. If we're going to build this system, what are the things that are important to you? And then what are the things important to FDA? This was really the data partners, us at the coordinating center, which is where Rich and I sit, and the data partners. So one, it has to accommodate the needs. So we knew what we needed to do. We knew our mission from FDA, so that was relatively clear. Had to be reasonable for the data partners. How are we going to organize the data? It had to make sense for them, or they wouldn't want to participate. Because we're building a network that was going to require frequent updating, the way we built the model had to really be appropriate for frequent updating and to be able to check it frequently. So that was an important piece of the process here. This next bullet is really thinking, let's keep it simple. I think all of the partners said, look, we can make these models can get really complicated, but there's probably no need to. Let's keep it simple and use all of our lessons learned from the prior networks to figure out how to do this. It was clearly a need to be able to expand to new data types. You'll see the kinds of data that we have in a slide and a couple slides. But the idea is we know the kind of data we need now. What will we need in the future? And the model had to be able to accommodate that as we built it. And in terms of use, we wanted to make sure that anytime we ask for information, we only ask for what we need. And that's we handle really with our governance and how we interact with each other. And it was very important that the programs execute without the site having to modify the program. So we can give it to them and they can execute the code and then get it back to us. And I think something that's not listed here is keeping the file simple and small becomes a really important topic. You can make the file, because we have data partners that really range in size from 100,000 members to 20 million, they'll have different needs in terms of the way the file should be structured. And we really had to talk through all of that to develop our first version of the model. The next slide. So the version 1, and this is on the Mini-Sentinel website, the details of the model is on the Mini-Sentinel website. So year 1 is done. We focused on, again, this administrative and claims data. Enrollment as a concept for health insurers, a start date and a stop date, The demographics is really pretty straightforward. This is outpatient pharmacy dispensing. So what we know is if it was filled, what was filled and on what day is really what we're getting here. We have a couple ways of organizing utilization. This is inpatient and outpatient utilization, and all of our partners collect the data with the same coding systems. So which is a benefit, and we knew that going in. So our diagnoses are ICD-9, the diagnosis codes, our procedures are either ICD-9s or HCPCS. And we knew that our outpatient pharmacies all are using NDC codes. So we had that going in, and that's the level of granularity we left it at. We actually included this mortality information because our data partners had it, and they said, why not include it? So we said, okay. What we're doing now, so year 2 is the current year, is expanding the data model to laboratory test results and vital signs. And the way we expand the model is basically by adding tables. And that's, we design the tables, and then you have the tables can be linked across each other, but adding a new laboratory results table doesn't impact any of the other tables. But the sites that have that information can add it, and the sites that don't can keep on going. And that's how you can build the system. So then the next piece. Next slide. So in developing the distributed database, that's really what we're referring to as the actual data that's sitting out with the data partners. Each partner, after going through the very detailed specifications of the data model, and that actually included every data partner going through every item in the data model and saying, yes, I can do this, or no, I can't, and asking questions if there was a question about it. And it took months and months of going back and forth to do that until we got to the same place. Only at that point did they do a transformation from their source data to the common model, and they documented exactly what they did to the level so they could recreate it, and we would understand what they were doing, and then it also including notes. So, we did this, but it's only good for this year forward, that kind of detail. And once they've done that, we at the operations center send code to each partner to do the data checking and completeness reporting, and that process is going to be do and repeat every quarter is the idea. So they did this transformation, we did the checking, and then we're going to do another transformation and then go through that whole checking process again. Because the back-end data change, so you always have to check it. It doesn't matter that it worked last time, you have to check it again. And that's just the way it goes. So the next slide. So this is really a little bit of a cartoon of how we interact with the network, and I'll get into details a little bit later, but there's the operations center up top, that's where Rich and I sit, and what do? We actually have a portal that we can log into, and we distribute a query to data partner 1 to data partner, we're now at 17. They go and grab the query and pull it into their system. So the query can come in many forms, but we can get into that later. It's a question that we can ask them. It's a structured question. They pull it into their firewall, through their firewall. They execute that query. They get the chance to review the results. You want them to be engaged. And then they send back those results back to the portal, and then we go and grab the results and go on our way. So we're asking a question, and they're giving an answer. And that's really the key piece. It's complicated to get it to happen, but that's really what we're trying to do, is keep it as simple as, here's my question, what's the answer? And they only give us back that answer. Next slide. So obviously you have to deal with security and privacy, even if you're moving count data, which is often what we're doing. So the network that we've developed sits in a FISMA-compliant data center, actually 2 FISMA-compliant data centers. The portal that we use is all standard security. And again, a piece of the security and privacy of the network, and this also I should mention includes proprietary interests of the data partners, of them protecting those interests. The data partners have control over their data at all times. They follow their own data sharing procedures, and they approve all the transmissions of the information back out. So we're not doing anything without their permission, and we don't touch their data, only they do. is a big piece of really what makes the network run and makes the data partners comfortable in working with us. So the next slide. So this is where are we now? These numbers will be updated pretty soon, but we've got about 71 million enrollees in the network. The left axis is the number of enrollees, the right is the number of data partners. So these numbers are from a previous data extract, which is why 2010 is low. It's because we didn't have the update of the next data for some of the data partners. So you can see the number of data partners engaged. But this is just a very simple description of the population. It's big and it's actually getting bigger. Next slide. So how do we get at the data? How do we really query those data sets that are sitting out at 17 different places, behind 17 different firewalls? We really have three approaches. One is a software tool we call the distributed query tool. We use that to get simple count data quickly. How many people were exposed to a drug? How many people had a flu vaccination last year? Those should be simple counts. We should be able to get them fast, and we do now. There's a second level of a second approach to get at the data, which is what we're calling modular programs. These are really just a little bit more sophisticated queries that you change your input parameters. The idea here is that the programs are standardized, so our data partners know what's coming, they know what the programs do, and they know what the output looks like. So we can skip over all of those questions and get them to the point where they're comfortable receiving the program, running it, and sending back the results. All of those programs had to go through a relatively long process. It wasn't too bad to get each partner comfortable that program was okay. The program didn't print the names of anyone. Well, there's no names in the database. It didn't print a line list. That once they got there, then that program doesn't change, and they're willing to run it. Those first two approaches get you handle a lot of relatively simple or straightforward questions, up to medium complexity kinds of questions. And then the next step is if those two things don't get the FDA, and these questions are coming from FDA, if they don't get you what you need, we write a piece of code, we test it. The code can be as complex as SAS programmers and an epidemiologist's imagination. And we write the code, we test the code, and then it goes out to the partners and they review the results. And typically after you do that process, that new code becomes part of your toolkit, and it ends up graduating to be a modular program, basically. Next slide. So these are a couple examples of the first set of modular programs. You can tell these are focused on FDA and actually on drug questions. So these are simple questions that we'll likely ask over and over again. So it's exposures for incident prevalent users, drug exposures for people with a particular condition. Find all the people with asthma and tell me what their drug use looks like. The third developed here is what's the rate of some outcome after the first exposure. So you find an incident user, so a new user of a drug, what's the rate of whatever outcome you select. And all of these are parameterized, and you can change the inputs. And then a concomitant use. So these are we expect to be common questions, so that's why we built these, and there's a whole other set for the next year. And they're just, basically they keep growing. Next slide. This is just a listing of a few of the things that we've done in the modular program. So we use modular program 1 to find out the rate of AMI among anti-diabetic users of anti-diabetic agents, AMI in stroke, characterize a population. And this was, FDA was asking, how does your over 60 population look compared to a Medicare population? So I can tell them what our population looks like, and they can take it and look at the Medicare population just to do some comparisons. And we've actually been doing a lot of what we've been calling these query tool counts. I think I have 5 here. We've probably done another 8 or 9 in the last week, where we're just getting at descriptive counts, and we get them really very quickly to help us think through. It's really to help us and FDA think through the best way to do an evaluation. Next slide. So I'm going to take a minute or two to talk about this networking software that we've developed actually with funding from ARC and then FDA to help facilitate these kinds of networks. So we've been doing this type of work for a long time, and now we've started to develop software that helps us do the work. So let's take the next slide. I'm going to use FDA. I'm going to keep FDA as the example. I'll just be a little bit more specific about what I really meant by a portal and how things work. So the software we're using, so if you look at the top right of the PopMedNet, that's the name of the software we're using for Mini-Sentinel to build this network. So what does the software do? It helps us create the network. It helps us interact with it's the format we use to interact with sites. We use the PopMedNet services, so we engage with a vendor to help build new services if we need them, and they run the secure portal. So we have this FISMA compliant portal. Someone has to run it. They manage that, and what we do is run the network. The PopMedNet runs think of it as the infrastructure and the pipes and the communications of the network, and we tell it what it should do. So that's the governance and who can do what within the network. We design the data model, et cetera, and we handle communication. So there's network functions and then there's software functions. So the middle big blue box is the Mini-Sentinel Secure Portal. So think of the portal as a website. It handles authentication. You're a user. What are you allowed to do? It handles query interfaces and viewing results. So we can really get these results wherever we happen to be, as long as I have an internet connection, send queries and see the results. And it's where the data partners can manage their settings, including auditing, so they can know exactly who's asked what and when. And there's a whole auditing stream that they really tend to like having the ability to use. So that's the software that we're using to engage. How does it work in practice? FDA gives us a call at the operations center. We go into the portal, and then we distribute the queries to the partners, and the partners get them back to us through the portal. So the next slide. This is the website is popmednet.org. So this has details of that software we developed. It's really generic. It wasn't developed for the Mini-Sentinel project. It's developed to create networks, and this is an application of that software to create the Mini-Sentinel network. So the next slide. So the key pieces of that software, I think the reason I think it's important to talk about this is these features are based on the needs of our data partners, and that's why it was developed in the way it was. So our partners really wanted role-based access control, who can do what. It gave the software gives the partners the ability to say yes and no to every question that is posed to it. It actually gives the partners the ability to let a query run fully automatic. It comes in, it runs, and the results are sent back, to fully manual, where every step of the way requires a person. Turning it on a little bit on its side in saying that the software was built based on the needs of the data partners, and now we're using it. But that has been the process, because ARC funded us to build the software, and now it's this implementation. I think I'm handing back over to Rich.
Okay, thanks. Next slide, please. So I'd like to spend the next few minutes talking about where we might go from here, based on sort of the general sort of needs of the learning healthcare system, sort of the general considerations about how one might evaluate these kinds of data and the experience that we've had so far. Next slide, please. This is a vision slide that was put together by FDA and Brookings that envisions essentially a national resource that consists of quality checked data that conforms to a common data model. So that's the big diamond in the middle. And then around the periphery are a number of different kinds of uses. So in the upper left-hand corner is medical product safety. That's the example we've been talking about. The FDA's interest in creating the Sentinel, the mini Sentinel, and eventually this Sentinel program. But it's easy to imagine other purpose-built programs that would focus on biomedical research in the lower left, the comparative effectiveness research at the bottom, quality of care in the upper right, public health surveillance, and other kinds of things, and it's in which there would be different governance rules that would be appropriate to the specific interests, needs, and requirements of the people and organizations that are asking the questions, and of the organizations that possess the data. And in our construct, although there's a single blue diamond in the middle representing the data are all living with the individual data partners. Next slide, please. We actually are starting to have experience with multiple uses of data through the FDA and a network that ARC is funding. It's the Scalable Partnering Network. Its acronym is SPAN. Next slide, please. I'll show you SPAN in a nutshell. Is a network of you can see at the bottom 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 organizations. Some of which are common to the Mini Sentinel, but not all. SPAN also uses PopMedNet as its networking software. But it has its own portal. The SPAN portal lives completely separately from the Mini Sentinel portal, but it serves the same function. So in the upper right, you see exactly the same 5 functions that PopMedNet provides to SPAN. And then SPAN is responsible for the activities in the lower right hand. In the large rectangle in the lower right is the highlight of what SPAN is doing. SPAN is actually creating 2 subnetworks that are looking at different research questions. One deals with a series of questions regarding attention deficit hyperactivity disorder, and the other has to do with obesity and obesity management. Next slide, please. And it has SPAN has many of the same attributes in terms of data partner control over activities. The purpose of this slide is to show that different data partners can participate in different pieces of the activities of SPAN. So on the data partner 1 has created 3 different data sets for ADHD studies and 3 different data sets for obesity studies, whereas data partner 2 is only participating in one of the ADHD studies and one of the obesity studies, and so has only stood up the data sets that are relevant there. Next slide, please. Now the future state that we are rapidly approaching is one in which a single data partner can participate in multiple networks. So what we show here is an organization that participates in SPAN, the Mini Sentinel, and something else. The something else doesn't really exist right now, but we're in a variety of conversations about other uses of this infrastructure. And the single client that the data partner has installed talks to each of these 3 portals, and it can distinguish the queries that are coming in from the 3 different portals and can apply the appropriate governance rules, can have different investigators or decision makers who are responsible for adjudicating the requests that come in and evaluating the responses that go out. In this example, the SPAN queries that come in from the left would basically be routed back to the SPAN data sets that live within the firewall. The Mini Sentinel queries would be routed to the Mini Sentinel data set, and the ones from another network would go to the data sets that are appropriate for that network. Next slide, please. Now, the important thing to note here is the same data set can be part of completely distinct networks. So there's the construction of these data sets is such that a Mini-Sentinel a data set that was created for the Mini-Sentinel program that has known characteristics can be queried by any other network, any other portal, subject to the data holder being willing to apply that query to the Mini-Sentinel database. So that takes us, we think, fairly close to the concept in that slide that I showed, the broader vision slide, in which a common set of data that are formatted in an agreed upon way and that have been sufficiently data checked can be used for multiple purposes, and allowing individual users to create to expand existing databases by adding new kinds of tables or by creating completely separate standalone databases. That takes us through the major things we were hoping to address with the group. The next slide just says, on behalf of both of us, thank you for the opportunity to lay some of these ideas out for you. We know that this audience is a sophisticated and thoughtful one, and we look forward to the discussion during the next half hour, and ideally we'd love to engage with as many of you as possible to get your advice and insight, and we'll feel free to help with some of these activities if you're interested in doing that. So, Kate, back to you.
Thank you, and what a great presentation. That was really very, very interesting. We do have some questions coming in, but I'm just going to remind our audience you can just type in your questions on the right-hand side, and we'll just jump in. So let's see. First of all, and I guess I'm going to, Rich and Jeff, I think I'm going to give you guys this one. You can pick. So the question is, are there any regulations that define acceptable forms of secondary use of electronic health data? And then what type of consent is needed for patients?
Well, it depends. I'd say it depends on the use. If the use is comparative effectiveness research, then the standard OHRP, Office of Human Research Protections, and HIPAA requirements apply. So it would be necessary to get appropriate IRB approvals for these and to comply with HIPAA privacy requirements. For the FDA work that we described, FDA and the OHRP have determined in a series in two complementary decisions that the work that we're doing is public health practice on behalf of FDA, and so this complies with the HIPAA public health provisions, but isn't part of the research oversight. So that's the long answer. The short answer is, yeah, there are plenty of regulations, but they're the ones that apply to the uses of health data generally.
Thank you. We have a question about, I guess this is how the patient information is pulled from multiple different providers. So how will an individual be connected with different providers? Are we using Social Security number? How do you pull the individual information from multiple different providers?
So linking individuals who have some data in each of several different places is an activity that's on our to-do list. So it's probably a longer topic than we can handle in this question and answer period, but it's a terrifically important one, and here's the 30-second answer: is we're exploring anonymous linkage methods that would allow two different data partners to know that they hold the same individual's data, so that if there's a need to put those data together, it can be done without requiring the unnecessary disclosure of many people's identifying information. But that's an activity that's in the works now.
And sounds like it's not trivial. It's pretty complicated. Let's see, we have another one. So will the private sector be able to access the data from the EHR data partners to develop applications for patients and or physicians? I think that's probably from the Mini-Sentinel network.
So there are two answers here. One is FDA is sort of actively working on developing policies that would address the ability of other organizations to access the data. The goal of this sort of notion of multiple use and a national resource is one that would allow an organization, a potential user, to approach the data partners directly. Part of the governance structure of the Mini-Sentinel is that the data partners have the right to use the data resources that they create for Mini-Sentinel for any purpose they choose to. So my expectation is that most of those other uses will take place through either direct contact between individual potential users and the data holders, or through these other coordinating functions that vision diagram envisions, a biomedical research sort of coordinating function, a CER coordinating function, and so on.
Here's another one. So what has been the level of participation by the data partners to move their local source data to common data model structure? And what, I guess I'll do the follow-up. Go ahead on that one. There's another follow-up to that.
The level of participation?
Yes, in terms of moving the local source data to a common model structure.
Okay.
Yeah.
So they do it all, basically. We worked hard on the model and for the data partners to understand it. We didn't presume to understand their local source data. We just made sure that we were speaking the same language and that they all agreed that they understood what the model meant. And then they did the extraction, transform, and load to that common model. And once they did that, we ran our data checking code. And then we had a whole other series of discussions if things came up that looked funny to us, then we went back and forth in one-on-one conversations with them. But they were in charge of doing that. We didn't get behind their firewall to touch their data at all.
And some of them had to install new servers and create a sort of the physical infrastructure to be able to accommodate these what are essentially reformatted copies of a large chunk of their data.
Yeah.
And then kind of the follow-up question there, what percentage of the data partners are willing to share the data only to FDA or HHS versus to the private sector?
At present, it's only to FDA. This is that's the short answer. Some of them also work with the private sector in a number of other roles. But Mini-Sentinel, for the time being, is a pure play serving FDA's needs.
And how long does it take for a response from the data partner once the query is submitted?
So there's two answers. For the query tool using the software where we're getting the very simple counts, they have a maximum of 2 days to respond. Most respond within 24 hours. probably about half respond within a few hours because it's relatively simple for them to do. For the modular programs that take a little bit longer to run, they're a little bit more complex, and they typically want to look at the results. We give them 5 days, and that's been plenty.
Jeff, can you estimate how much actual person time does it take for them to respond to both those kinds of queries?
So person time for that query tool queries and using that PubMedNet software, it takes probably about 15 minutes. It really is a point-and-click kind of process. For the modular programs, I would probably give an analyst an hour or two of time to do it. They're not doing, there's plus the time it takes to run. The program might actually run for 2 or 3 hours. But it takes a little bit of time, probably 10 or 15 minutes to read the documentation and change a line in the code, and then review. They always tend to want to review the output files, and that's another 20, 30 minutes to look at those files.
So the response periods that Jeff described to you are the ones we've established as sort of normal operations. If FDA has an urgent need, effectively we can answer the question the same day. It's just a question of priorities, but the technical capability is there to design, submit, collate the responses, and provide a coherent response to FDA within a few hours if it's a matter that's really sort of vital urgency.
And what methods do you use to combine the response, from the various partners into a single estimate or response?
So there's probably 3 different answers. The simple one is for the querying tool and the modular program kind of work, the results are typically count data, and you can really just add them together. It's as simple as bringing them back. We bring them back in either Excel or SAS files, and we quite honestly just line them up and add them together. Because we know exactly what those results we know what the format of the results will be. We just don't know what the numbers will be. For an evaluation, if we're doing a formal evaluation, then it will depend on the question that's being asked. Sometimes the evaluation will also generate count data, in which case it really is just aggregating stratified counts together. If the evaluation requires more fine-level data sets, then might bring them together to do a cost proportional hazards model or some kind of multivariable model. But for the ad hoc evaluation, it'll depend specifically on the question being asked of how you would put the data together.
And how do you deal with estimates of uncertainty in that? I guess if they're just counts, maybe that's not relevant, but if you have a range or something like that where it's not quite as clear-cut.
We use a variety of statistical tools to deal with, for the count data, to deal with stratified data. There are some of the work we're doing takes us into terrain where the statistics haven't been terribly well defined, and so we're doing some methodologic work on there. But we use to a guy like me fairly sophisticated statistical analytical techniques to estimate the precision around an estimate and a substantial amount of epidemiologic methods to adjust for confounding and effect modification.
Do the panelists know of any examples of automated monitoring of data in real time?
The fastest we've ever done it. So the question is how fast. The limitation is the speed of refreshing the data sources, and in principle, there's no lower bound. The fastest we've done it on a scale approaching the number of organizations and size of populations was in monitoring the safety of the H1N1 influenza vaccine. And there, sort of the fastest that any of our data partners could effectively refresh their data was weekly. In other situations, we've done some work, not as part of this mini Sentinel activity, of biosurveillance, where there's interest in looking for acute clusters of that might signal an influenza outbreak, or essentially got started when we were looking for anthrax. And there we were doing nightly extracts from electronic health records, and so by 10 o'clock in the morning we would have results from 5 large metropolitan areas across the country that were sort of fully digested and reported back.
Can the data partners query the rest of the data partners in doing their own reporting and benchmarking, or is it all sort of triggered by FDA?
Yeah. PopMedNet has that capability, that data partners can allow each other to query them. That capability is not enabled in the Mini Sentinel, however. But it would take them a few minutes to decide with each other that they wanted to allow that, and so there's no new programming that's involved. That's a toggle that's set. So it's the capability is built into the software that Jeff described.
Yeah, within Mini Sentinel, all the partners can query themselves if they'd like to, or we query them. Set up another network where they can query each other. It's exactly how Rich said. It's simply giving someone permission to do it.
Since each partner could have data in different formats and code sets, how will this scale to thousands of partners?
The key here is a common data model. So while each of our data partners has data in a different form, they really negotiated amongst themselves to develop a common data model that accommodated the largest set of needs and interests. But every one of them had to convert its data into a standard format. So that will likely be the case for any organization that's interested in participating here. My take is there's good news and bad news ahead of us. The good news is that there will be a substantial amount of standardization of electronic health records. The bad news is that there's a fair amount of local flexibility built into the electronic health record product, so that even though several of the organizations that are participating are using exactly the same EHR vendor, their local customization is sufficiently different that each one has to put meaningful thought into the transform part of the extract, transform, and load. We don't see a way around that requirement, and we appreciate that it is a substantial lift.
So if an individual goes to multiple medical providers for the same condition, can that person's medical information be doubled or tripled on different queries? So when you get multiple responses on the same person?
We should be able to find most of that because we're dealing with. Remember, one of the things we listed as a must-have criterion is complete information on defined populations. So we believe for the populations that are under observation here, we believe that we have a complete record of all the medical care that they received, even from different providers. And so we believe that we will not identify the same person as being a new diabetic more than once. We haven't yet started to link across the data partners we have now, though. So if, for instance, a person disenrolls from one health insurer and enrolls with another, and both are part of Mini-Sentinel, we don't yet link the data for that person longitudinally. However, we still wouldn't identify, we are very unlikely to identify that same person as being an incident diabetic in both systems because of the requirements that we impose on the definition of an incident case. So that the person who meets that criterion in the first, with the first insurer would be almost impossible to meet. It would be very unlikely to meet that criterion after enrolling with the second insurer.
So we still have quite a few questions coming in. I just want to let our audience know that if we run out of time before we get all the questions answered, we will work with our speakers offline and post the Q&A if we don't get to all of them. We'll keep rolling here. We have a few more minutes. So what is the strategy on the learning health system and building a public health informatics network and system as a collaboration in all levels from local, state, federal, et cetera? And maybe, I don't know, Chuck, do you want to take that one? Or...
Sure. I can talk about one project that's underway that I did make reference to in the first session of this series. We actually have within the government formed something that we've been calling on an interim basis the Learning Health System Coalition. And this is a group of 7 projects spanning 4 agencies, notably 3 of them from the CDC, who have agreed to work together to explore how the 7 infrastructures currently supporting or plan to support these 7 projects might be collapsed into a smaller number of services that is supporting more than one of them. This is very harmonious with some of the slides that Rich and Jeff showed about their vision for how things may look forward in the future. What sort of sets this project apart is that it's a group of federal agencies and learning health system-like projects that are very much engaged with public health, and we're not exactly sure what this coalition is going to evolve into, but we expect that it will grow, and it could be the seed of the vision that whoever the person is who asked this excellent question had in mind when he put forward the question.
Great. I think we really have time for just 1 or 2 more. Here's one. So currently the federal government is creating a health information system for Medicaid and Medicare recipients. Is this a different system, or will HHS be using the same system? I guess I'm going to give that to you too, Chuck.
Okay. So I'm not exactly sure of the precise thrust of this question, but one way to interpret it would send me in the direction of making a clarification. I think that the involvement of Medicare and Medicaid under the HITECH Act is to provide incentives to eligible professionals and hospitals that achieve meaningful use of health IT. Even though the incentives are paid through the Medicare and Medicaid program, I think it's safe to say that the goals of this program transcend the care that is delivered and reimbursed through Medicare and Medicaid per se. So the Medicare so the system that is being set up, including the standards that are being adopted and the certification criteria and certification process that are in place, and the attestation of meaningful use itself certainly all relate to Medicare and Medicaid, but as I said before, the aspirations are much higher and much more general and nationwide in scope, extending even to the learning health system that I articulated in my initial remarks today, and that Rich and Jeff have really expanded on in very significant ways. I hope that reflected the intent of the question, but I'm not exactly sure.
Thank you, Chuck. A couple more on the data sharing. So is there an incentive for data partners to continue to share their data, or is there an FDA mandate or requirement?
It's voluntary on the part of the data partners. The data partners have, I think, all the usual interests in both in contributing to the general state of knowledge about the safety of medical products, and in being able to learn more about ways they can protect their own patients. But there's nothing mandatory about this.
Is there a cost associated with participation of the data partners?
FDA reimburses the data partners' cost.
Great. Okay, I think we're going to have to bring this to a close. We're about out of time. So I want to really thank Chuck and Rich and Jeff for wonderful presentations. I think we also had some really interesting and thought-provoking questions. So thank you to our audience for that. And before you all sign off, please do just take a moment and complete the short survey that we've popped up on the screen there. We really do need your feedback. And once again, thank you so much to our speakers, and thank you all for attending the program today. We do hope you will join us for our upcoming programs. In particular, remember, next Thursday we have our final class in the Spotlight Learning Series on accountable care. So thank you very much, everyone, and have a great day.
Thank you.